I'll be talking about open globe injury, the real battlefield. Just a sec. Yeah. Just to introduce the Birmingham eye trauma terminology system, it has been discussed in detail by Dr. Devesh. So I'll be dealing with the open globe injury. So open globe injury as per the ocular trauma classification has further been classified. Here I would just like you to look at this image. So we classify it into different zones. The zone 1 is the yellow image, which extends up to the cornea and the limbus. Zone 2 is limbus up to 5 mm posterior into the sclera. And zone 3, the blue zone, is posterior to 5 mm from the limbus. So first things first, when we come across a case of ocular trauma, we must assess, counsel, prognosticate, and timely refer any patient if needed. Any life-threatening injury must take precedence over ocular trauma. So what are the investigations that we would go ahead with a patient who presents with ocular trauma? Routine hematological investigation should be done, as most of these cases would be managed under general anesthesia. An X-ray orbit is a must in all cases to rule out any orbital wall fracture or an intraorbital or ocular foreign body. CT can be done if there is a suspicion of a bony injury, and for any soft tissue lesions, we usually go ahead with an MRI. The ultrasonography for posterior segment evaluation should be used with extreme caution because of open globe injury, which can lead to further damage. The first aid, we do not apply any pressure on the eyeball in cases of any globe rupture. We can apply a shield. A tetanus immunization should be done, and systemic analgesics and antibiotics can be started. A comprehensive workup must be done for all cases. So we must look at all the structures of the eye. We assess the conjunctiva for any chemosis, hemorrhage, the subconjunctival space. Similarly, the cornea, the sclera, anterior chamber, iris, the length, and the posterior segment should be thoroughly evaluated. So what are the goals of management of open globe injury? We must ensure a watertight globe and maintain the globe integrity and normal intraocular pressure. To remove any contaminated and non-viable tissue and any foreign body if present, to reposit the viable tissue and to restore the original anatomy, and to avoid any iatrogenic damage and restore the visual function if possible. So coming down to corneal lacerations, they can be further divided into partial thickness and full thickness lacerations. As discussed, sedals and pressure sedals should be performed to differentiate between the two. Now coming to full thickness lacerations, they can be simple lacerations, which can be simply managed with corneal sutures. If there's associated uveal incarceration, it can either be reposited or abscissed based on the scenario of the case. If there's associated lens involvement, a lensectomy may be required. If associated vitreous involvement, we may have to go ahead with a vitrectomy. For scleral involvement, we need scleral sutures. And if there's associated tissue loss, a patch graft or a penetrating keratoplasty may be required. So coming to the choice of anesthesia, most of the cases are managed under general anesthesia, which gives us a dual benefit of excellent anesthesia as well as akinesia. And there is a minimal increase in the intraocular and the intraorbital pressure. Topical or a local anesthesia is suitable for small anterior defects. So coming to ocular triage, the first aim is the globe. So repair of the adnexal injury should follow repair of the globe. Any eyelid surgery can put pressure on an open globe. So now I would like to discuss about suturing. So what is an optimal suture? A suture which makes the wound watertight, minimizes postoperative edema, minimizes scar formation, minimizes interference with the corneal curvature, and minimizes any late complications. So now coming down to suturing of a corneal perforation, the first thing we do is to identify the anatomical landmarks, because the goal is to preserve as much anatomy as possible. We secure the landmarks first, especially the limbus, to save the anatomy. Now the type and technique of suturing. For cornea, we use a 10-ohm monofilament suture on a fine spatulated microsurgical needle, and the intended depth of suturing is 90 to 95% of the stroma. The usual suture length is 1.5 millimeters with an equal depth on either side. We progressively halve the wound with simple interrupted sutures, and for corneal sutures, we perform 3 throws. For corneal suturing, we use the no-touch technique, which prevents further damage to the already edematous cornea. Now coming down to management of vertical lacerations, as you see in the first image, that is the correct technique of suturing, where the entry and the exit points of the suture should be equidistant from the laceration. However, this does not hold true for shelf lacerations, where the entry and the exit points of the suture should be equal on the posterior surface from the laceration. So here the second image represents the correct technique, and the first technique would lead to tissue overriding. Now, how many sutures should be done? So basically that is based on the compression zones, which have a roughly triangular configuration extending approximately one half of the suture length on either direction. So here, if we see, the length of the suture should be equal to the distance of the suture, which will result in no astigmatism. So this is the correct technique seen by the second image. The Rossi-Hayes technique is given for corneal suturing for linear perforations, which aids in preserving the normal spherical contour of the central cornea, where it gives short central bites and long peripheral bites. Now, coming to the management of angular corneal wounds, the initial suture should be placed in the angle of the laceration as seen in the image. We suture from the angle and not towards the angle. For complex wounds, similar rule is followed for all angulations. We treat them as multiple separate laceration and the central part is closed last. Now, different techniques have been given for management of triradiate and the stellate corneal perforation. This is the Atkins method. Also, the Eisner's method is given for stellate corneal perforations. Now, I would like to discuss about corneoscleral lacerations. How do we manage them? A 360-degree peritomy is done and the tenons is retracted posteriorly. The scleral wounds are closed with the close as you go technique. If there is the recti that comes in between, disinsertion and reinsertion may be done. Interrupted sutures are passed through the deep sclera at a depth of 80%. We use 6-0 vicryl, which is an absorbable suture. And forceps use is mandatory as opposed to the cornea to securely grasp the resistant sclera in case of a scleral perforation. So now this is just a graphical image representation of a surgical case of corneoscleral perforation. So the image on the right shows the case at the beginning of the surgery where we can see a linear corneoscleral perforation with uveal tissue prolapse. So the first step would be to clear the debris, all the vitreous and the uveal tissue, and then secure the limbus, that is our anatomical landmark. Here you can see the suture is being passed at the limbus. Then the cornea is managed second. You can see the Rossi-Hayes technique has been followed here. And then we repair the scleral component, and at the end of the surgery we have an airtight globe. So the golden rule is the LCS, that we first secure the limbus followed by the cornea and then the sclera. Now coming to the management of prolapsed iris, whether to reposit or not to reposit. So the aim is to preserve as much uveal tissue as possible, but there is no magical period. We consider 24 to 36 hours as the maximal safe period. If there is any apparent or visible infective corneal laceration, we do not recommend to reposit the uveal tissue. If the tissue is necrotic, do not reposit. For the management of associated lens matter, there are few indications to do a primary lens aspiration in case of disrupted lens capsule with flocculent cortical matter, cases in which vitreous is involved, and where lens is cataractous and surgical visualization is good, which is based on the surgeon's preference. However, other cases, elective cataract surgery should be done. Now, for management of corneal perforations with tissue loss, the methods of wound closure can be with the help of fibrin glue or a cyanoacrylate glue. I'll just sum up. Amniotic membrane transplantation, a Gunderson flap, or a donor cornea can also be used. I'll skip the surgical video. And lastly, for the post-operative management, a patch or a shield can be placed. Topical steroids are a must, antibiotics, cycloplegics, and timely suture removal. Thank you.